Hello, good afternoon to everyone. Today I am going to demonstrate you prostate surgery by laser, that is three lobe technique. There are several techniques to remove this prostate by laser. So today I'll be demonstrating you three lobe technique. As you've seen here, this is a case of 60-year male patient, and these are the enlarged prostate, about 36 gram with the high post-void residual urine. And this patient uh, has enlarged both the lateral lobes and some high neck and trabeculated bladder, as you can see here. And we did the aeroflowmetry and also showing that it's about 12 ml per second. So this is the laser, and I have been using this holmium laser. It's a 65 watt laser, but we are using only 50 watt to remove this prostate. Now first my aim is to remove this median lobe. As you can see here, initially uh, I mark the distal margin, as you can see here. Uh, some people do just give in like a nick incision, which is not adequate. Uh, I prefer to give or make a raw area to this distal margin. As you can see here, this is the distal end, and going down right and left close to the veru. So this is just a marking, and initial my aim is to remove this median lobe incision at the 5 o'clock, as you can see here, going down to the veru. Now once we cut this at the 5 o'clock, and many of our friends and new urologists, they ask me their concern about how deep to cut this incision. As you can see here, we are deepening down from till from there you can see the left ureteric orifice. See, you can see go down, and also you can see the circular fiber at the neck, which means you are at the capsular level. So that is the mark for the how much deep to go down. Similarly, as we have given incision at 5 o'clock, and we start on the another side, that's 7 o'clock. It's in the same pattern, same manner. As you can see here, just keep a laser and it will gradually separate this adenoma, and nothing much to worry. And it is holmium is for enucleation, as we all know that, and it's very easy, convenient. And if you use I used to do diode laser, which gives the picture of thulium laser, which means there are so many charring during the procedure, and I really don't like that. But this is a new holmium, and holmium is for the prostate surgery. That's my belief. As you can see here, now proximal to the verumentinum, after giving incision, now we can nicely see this prostatic capsule, and just follow them, and you see, just follow. And here is the 7 o'clock incision, and you just connect the previous incision with this one. So everything is under vision on everything. Now similarly, you can lift this, you can give incision and lift the adenoma, as you can see here, gradual lifting. So nothing is blindly done, and this is an unedited video. As you can see here, we are not editing anything, and this is about 36 gram prostate. And to remove this median lobe, it takes hardly about 5 to 7 minutes, not more than. Even in a larger gland, adenoma separates very easily and very fast. So it doesn't take much. Once you clear this median lobe, then you can have a very nice irrigation flow, which gives you the good vision in the entire procedure. So actually, my routine practice is en bloc, but sometimes we do this um, tree lobe technique also, which is also very fast. The reason behind the fast in tree lobe technique I will share you later, why it is fast. So see, if you see 6 minutes to remove this median lobe, very fast, convenient, bloodless procedure. Once I remove this median lobe, then gradually I come back and give an incision at 2 o'clock on the either side to 12 o'clock. Then this incision will be advanced on the right side and left side. See, this is just to remove this median lobe. It's taking hardly 6 minutes, 7 minutes altogether. That's all. It's completely bloodless procedure, as you can see here. And now we are just inspecting, see the any bleeder. If we observe that, then we can coagulate it, and this procedure can be done without blood. See, this is our previous incision, and now we start at 12 o'clock. Here is the removed tissue from median lobe. If there is any bleeding, we can coagulate anytime. And see, this is the distal end, so it's not very large. Now what we do is just like draw a line from proximal to distal. Once you are at the capsular level, then we can sweep on the right side and left side. And how to identify this capsular plane? So whatever we see, this yellow tissue, that's adenoma. And once you have a pure white circular fiber, then that's the capsular plane, and we can move our laser on the right side and the left side. So once we are in the capsular plane, the adenoma separates very easily. You don't have to apply any force during the procedure. As I'm showing you here now, what we do is just gradually, as you can see here at the neck, these circular fibers, these are the capsular plane. See, now gradually you advance from proximal to distal. Just follow that circular capsular plane. Even if there is some mild tissue, residual tissue, we don't, later we can clear it, doesn't matter. And as you can see here, we are just at the capsular plane, so we can advance and go down up to the 3 o'clock. So it will be more convenient to later come from the distal end. See, this is now almost at the 3 o'clock. It took us about 6 minutes from 12 o'clock to give incision, for the left lobe. See, anytime we can correct our plane. If there is any residual prostate, we can correct it. Okay, this is on the left side, right? and if there is any bleeding, we can notice, we can coagulate it. See, this procedure, the beauty of Halmium is it's a bloodless procedure, as I can say that. And now once we have finished incision given till 3 o'clock, then we can start on the right lobe. See, this is the distal end as we have marked earlier during our procedure. And see, just follow, just carefully see the adenoma, which means the all yellow gland, and see the capsular plane. Very careful, there is nothing hard. We can continue slowly and find the plane nicely. See, and we can take time, it's nothing urgent. And the main aim is to have a patient a good flow after the surgery, not to have incontinence. That is the biggest issue for the people and for us. So if we are a bit careful, we can avoid all these complications. And as we are using this MiLEP technique, it's a 22 French, and most of our patients, it's a drastically, the urethral stricture is drastically decreased with the MiLEP technique, as it's 22 French and easily negotiable to the urethra. And you can see here we have now almost reached to the 9 o'clock. You can see this prostate adenoma free from the roof. Now what we do is either we can give incision at 5 o'clock or 7 o'clock. You can see when there is, we can find a stone, that means that's a capsular plane. See, as you can see here, and we can continue with that. Somewhat we can make some mechanical push at this point, and you can clearly see the adenoma. See, this is at the 5 o'clock, gradually from up to down, down to up. Once we can see the capsular plane, we can advance it, and main aim is to not to perforate the capsular plane whenever possible, but sometimes we cannot avoid that. See, very nicely seen capsular plane and adenoma. Once we are at the capsular plane, and it separates very easily. When we have to apply some force, means we are not at the proper plane. So just follow this plane from 5 o'clock to the 12 o'clock, and the most challenging all the time is somewhere at the 10 to 2 o'clock, and 10 to 12 o'clock, and 2 to 12 o'clock. So these are the challenging places, so you have to be very careful at those points, because sometimes the sphincter is pulled. And just follow the adenoma, that will take you the procedure so smoothly. As you can see here, some residual tissue we can manage later also after the procedure, which can be managed very easily. If we have any doubt, see, now it's open at 1 to 2 o'clock, as we have already opened up to the from 12 to 3 o'clock. So in three lobe technique, the main, if we are doing in block, it takes some time from 10 to 12, 12 to 2 a.m. But it's in block technique. However, in three lobe technique, as we separate from 12 to 3 and 12 to 9 o'clock, so it saves time. So as you can see here, we can connect these lines which were already detached from 12 to 3 o'clock, and see all the attachments can be uh, detached by the laser, and whenever we see this bleeding, and we can coagulate it, and so it's really fun to do HOLEP, and I advise all the young guys to learn this technique. Once you do this, you will forget all TURP and bipolar. See, if you see the guidelines and all, uh, laser or enucleation is advisable only for more than 50 gram. But what I say with my experience, these lasers can be done in at any size of prostate. And if you see, this is just a 36 gram prostate. We completed in 20 minutes. So that is just in the textbook or the guideline, and I recommend all the young generation people, guys, and it takes time for your practice, but one must learn this technique, and it doesn't, it's a you can save your time also. It's not time consuming. The only thing one must do this enucleation at least about 50 cases, and start with around 45 gram prostate, where you can enucleate prostate nicely. And yes, of course, there is sometimes there is some difficulty in small, but however not all the time. Once we know our limit, we know our landmark, then nothing is difficult. See, these are small residual tissue, and we are moving. Now we are moving distal in, and we can see very clearly whatever the attachment with the prostate, we can vaporize it, also enucleate it nicely. So we know our distal end, that is the key in prostate. Patient should not be incontinence after the surgery, and this HOLEP, it's not a kind time consuming. Yes, of course, if you are doing larger gland in your initial career, maybe you may face difficulty, but once you became a master, and then you will love to do every day this case, because every case is different, every gland is different, some are hard, some are juicy. So I love to do all these HOLEP cases, and we really enjoy doing it, and our patients are extremely happy after the surgery. See, now it's about, this is completely unedited video to demonstrate for the young guys and our friends who are interested to learn this uh, three lobe technique. The key again is to know our landmark. So the left lobe is almost done. It's completely clear. That's the left lobe, completely detached. Now, now see small tissue coming up like a hump, and what we can do is, in such cases, we can do some vaporization also. So there are sometimes multinodular um, gland. So even after we think that we are just uh, following the capsular plane, still below that we can see this nodular growth. See, this is the distal end, and we don't need to worry about the uh, incontinence. We are just at the place where we initially marked, and this is so only this one is the left side, and now we are, oh, there is some residual stone, as I mentioned, small nodular growth remaining, and this is completion of the left lobe. See, now how we start on the right side. So always advisable to do complete one lobe, so I just remove my telescope, and I intermittently prefer to keep uh, jelly, because Nepalese urethra is bit small, and intermittently if we keep some jellies, so that can avoid the strictures. Now we are starting working on the will work on the right lobe. As you can see here, whatever the bleeding, we can spend 1 or 2 minutes for the hemostasis, and that's the Veru. Now we are giving incision at the 7 o'clock. Now advance it till we see the capsular plane. See, now coming down, we can see the capsular plane. Once we are at the plane, then we can do some mechanical push also, uh, which will which will see now we can see it very clearly. We can see it very clearly. See, that's the adenoma, and just give the incision towards the from 7 o'clock to 8 o'clock, as you can see here. Now we don't need to be very fast, be very precise, stay on the capsular plane, not to go much deep inside, and see, and this is adenoma, as you can see here. This is just follow that like a semicircle from 6 o'clock to again 10 o'clock. See, advance it whenever possible. You can minimize our time, save our time, or sometimes mechanical push like this. See, beautifully pushed, and once we can identify this capsular plane, then we can increase our speed so that we don't spend so much time doing this procedure. And by this technique, we can also do every day 3 or 4 cases of MiLEP of this size. Even the bigger prostate is much easier, because we can separate adenoma easily than the smaller one. And still, whether it's a small gland or a big gland, it doesn't matter, only the time matters. As you can see here, see, so we are trying to separate, and we are trying to connect the previous uh, mark, which was from the 12 o'clock to 9 o'clock incision. So we are just going to connect that line, and see adenoma, and that's the bladder, you can see, and we can just advance it. Nothing much to worry. See, just stay at the plane. And now here, at some people they got at the adenoma, some people at the capsular plane, but I prefer to go at the groove between the adenoma and the groove between adenoma and the plane. See, nicely it separates, uh, not much effort, and very nice uh, going. And only the key here is to understand the anatomy, understand uh, the landmark. That is very, very essential, and it takes time to learn this technique. The learning curve is a bit steep in HOLIP. It's not like a TUR or bipolar, but once you do few cases, will be used to it. Previously, I have uh, demonstrated this N block procedure in 30 gram prostate with the 12 minutes duration. And if you see here, even this prostate, uh, it's about 26 minutes so far. We are almost at the bladder neck, as you can see here. So it doesn't take much time. Only when we got lost, we cannot find the capsular plane. Yes, in that situation, in a big prostate, it may take some time. So this is all about the resex en bloc. I mean the tree lobe technique. As you can see here, this is right lobe, and there is some residual tissue. So we can resect anytime. It doesn't take much time. You see, we can cut it whenever we feel or we see some tissue after enucleation. And as I earlier mentioned that in some prostate there may be a chances of multinodular growth. It's a benign nodular growth, and we can resect anytime. That's not an issue. Main aim is to have a proper urination of the patient after the surgery. That is the key. Whether some people may not enucleate all the gland, but once you are doing HOLIP, it's better to remove as much as possible all the tissue. So this is the beauty. It's a small gland. We are trying to push, cut with the laser and remove this tissue. So this is the beauty of holmium laser enucleation, whether we do en bloc or the tree lobe technique. So we have done up to 220 gram prostate also. It doesn't make any problem. And so the thing in big prostate is there may be sometimes a limited space when you are working at the adenoma and the capsular plane. See, we are finishing almost this residual tissue. Then we use the morcellator. I have been using this morcellator from China for more than 12 years, which is good enough to morcellate the tissue and very effective, and which is much cheaper compared to other companies like Olympus and other companies. So I prefer these are equally like other branded one. And as I told you that we have been using for almost 14 years morcellator, and so now it's about 29 minutes from the very beginning, and this is as I mentioned, it's unedited video. Now what we do is, you can see that's the fossa. That's the fossa, and if we see any bleeding, we can coagulate instantly. See, these are all the prostate, and this is the distal margin. And so we don't see incontinent patient in our practice. Most of our patients are good. They are happy with the MiLEP, and we do have this 24.5 French, but these days we are using this 22 French, and we hardly see this stricture. Yes, obviously some people they develop stricture, but we can minimize it with the using of MiLEP telescope. See, probably I have completed the procedure. See, that's the fossa, and once hemostasis is secured, then we'll go with the morcellation. So it's a 31 minutes from the beginning. So I prefer to keep at least two nights catheter, if needed irrigation, and 2 nights mean 48 hours with the IV antibiotics. So coming to the morcellation part, as I mentioned, 36 gram, it hardly takes 3 minutes to do morcellation in these glands. So it doesn't take much time. Just you have to be used to with the morcelloscope, and this bladder should be filled with the irrigation fluid, and it doesn't take much time. So it is much faster. One has to be careful with the bladder. That's the key. And always examine the bladder with these patients before you start. See, if you see the bladder, it's completely full, and hardly 2 to 3 minutes for 30 gram prostate. So this is the end of procedure, and you can see almost done, and you can see the it's unedited, all this small tissue left, very fast. And some light tissues, they may run away from your scope. In such case, you close your irrigation, and this tissue will come back to you and give some suction with the morcellator, and you can see all this tissue. See, you can see this tissue coming will come back to you. So the only thing is, for the short moment, you close your irrigation. So see, that's the prostate fossa. That's the beauty of Holmium laser. So thank you very much. And this, I have checked the sphincter also. It's nicely intact, and see, you can see here coming back. Yeah, and, this is the sphincter, as you can see here, coming a small tissue, small amount of tissue. So you can always inspect the entire system repeatedly, so that no tissue remaining there. So that's the end. Thank you very much for watching, and this is the sphincter, as you can see here. Okay, thank you.